Hi, my name is Lars Ny. I'm a consultant in oncology at the Sahlgrenska University Hospital in Gothenburg, Sweden.
And I'm Jonas Nilsson, a professor of melanoma discovery at Harry Perkins Institute of Medical Research in Perth.
Here we present the data and results from the PEMDAC phase 2 study that we have carried out using pembrolizumab and entinostat in patients with metastatic uveal melanoma. Uveal melanoma represent a rare form of melanoma that approximately affect 2% of all patients with melanoma. Today we have effective treatment for the primary tumor, including irradiation and surgery. 50% of all patients with uveal melanoma will eventually develop metastatic disease that mainly affects the liver. For metastatic disease, however, there are no effective and approved therapies, including targeted therapy and immunotherapy. With the condition that mainly affecting the liver, we have in Sweden and Gothenburg tried to evaluate local therapy for this group of patients. This has led to the initiation of the Scandium trial, and that was initiated 10 years ago almost, randomizing patients with isolated hepatic perfusion in comparison to best alternative care. Best alternative care for those patients is, as you may understand, very challenging since we don't have any effective treatment. And that led us to see if we can identify opportunities for this group of patients.
So previously in the group, we had been working on epigenetic therapy, and in a publication in PNAS 2014, we were able to show that BET bromodomain inhibitors impair antigen presentations, whereas HDAC inhibitor induce antigen presentation. So we were wondering if this potentially could happen also in uveal melanoma. So the aim of this project was to investigate the effects of HDAC inhibitors on uveal melanoma cells and T-cell immunity. So to do that, we cultured uveal melanoma cells in the presence of the HDAC inhibitor entinostat and found that this reshapes the transcriptome of uveal melanoma, including both antigen processing and presenting pathways, checkpoint ligands, checkpoint proteins, and interleukins. We could demonstrate that HLA genes, HLA A, B, C, were induced in these cells by entinostat. But rather counterintuitively, we also saw that entinostat induced PD-L1, which is a negative regulator of T cells. So this suggested that if entinostat was going to be used in treatment of uveal melanoma, that then also PD-1, PD-L1 had to be inhibited. So to test that, we turned into a mouse model, the B16 melanoma model, and to first do a control, we cultured these cells in vitro and saw that entinostat induced both HLA as well as PD-L1. And the induction of PD-L1 was most likely the reason why treatment of these tumor-bearing mice with entinostat alone resulted in acceleration of disease. And when we knocked out PD-L1 from these B16 cells and repeated the experiment, we saw that entinostat no longer induced the proliferation and growth of these cells in vivo. And in fact, combining this entinostat with a PD-L1 knockout resulted in an even more suppression of growth. And this could also be recapitulated using an antibody targeting PD-1 in the mouse. And these are data that are present in a publication that we are trying to publish at the moment. So we also went and tried combining entinostat with immune therapy in cultured human uveal melanoma cells by treating cells with entinostat and then giving the cells HLA-matched uveal melanoma TILs. And then we analyzed the expression of caspase-3, cleaved caspase-3 as a marker of apoptosis, and we see that entinostat induces apoptosis, TILs induces apoptosis, but if you combine the two, the apoptosis is even more elevated. And this is correlated with deposition of granzyme B into the tumor cells, which is synergistically elevated by combining entinostat with TILs. So this gave us preclinical suggestions that entinostat induces MHC expression, but hampers immunity by inducing PD-L1 on tumor cells. And in a syngeneic mouse model, enhanced efficacy with combination of entinostat and anti-PD-1 antibody could be observed. And combination of entinostat and immunotherapy shows potent killing of human uveal melanoma cell lines. So our research hypothesis was then, will then HDAC inhibitor entinostat increase clinical efficacy of pembrolizumab?
And this led also to design of a trial that you will find on clinicaltrials.gov. This is an open label phase 2 study that has been carried out at the 4 university hospitals in Sweden, including patients from all the country, and using entinostat 5 milligrams orally once weekly in combination with pembrolizumab 200 milligrams IV every 3 weeks. We enrolled 29 patients according to pre-specified criteria with metastatic uveal melanoma, including both treatment naive and previously treated patients. However, no patients had received immunotherapy before enrollment. The primary endpoint was overall response rate according to RECIST 1.1, and pre-specified criteria said that we should have more than 4 responses to have a positive study. Secondary endpoints included clinical benefit rate, progression-free survival, overall survival, and safety. And then there are a number of exploratory endpoints, including circulating tumor DNA, genetics, and immunology. In this swimmer plot, you see the responses, and as you can see, we had 2 patients already at the first scanning demonstrating clear tumor shrinkage. 2 of the patients with response was later on in therapy. A number of patients are still on treatment after this first database lock. And as you can imagine, there are also a number of patients that have actually died due to the condition. In the left panel, you see the waterfall plot with responses, and on the right in green, you see the 4 subjects with partial response. To the right, you see in the spider plot durable responses in those patients. And the trial demonstrated that we had 4 out of 29 patients with the response. And one of them you can see in these CT scans with a patient with a quite large tumor burden in the lower thoracic compartment and the upper abdomen that already at week 9 demonstrate tumor shrinkage that was further in week 27. In the left, progression-free survival at the median 2.1 months, and on the right, overall survival median 13.4 months. For overall survival, we clearly passed the benchmark of survival of 10 months that is considered to be the standard in this group of patients. Safety was manageable, and we did see toxicity and adverse events in a majority of patients. but with experienced staff handling immunotherapy, that was not really an issue. Correlating to the entinostat treatment, there was a need for reduction in dose to handle hematological toxicity, and that went out fine. We only had 3 patients that needed to discontinue due to adverse events, and we did not see any fatal events.
So with the 4 responders, we were of course interested in identifying potential biomarkers of response and survival in this study. So we did a long list of exploratory analysis. One of them was analyzing the level of ctDNA, which is DNA that can be released from tumors via apoptosis, necrosis, and also secretion. So as you can see here to the left, you can see that all of the responders in green at one time point during the trial reached the undetectable level of ctDNA. And interestingly, low levels of ctDNA correlated also with survival. So of the patients which had low levels of ctDNA, they survived much longer than those that had higher levels. And we believe that this is due to tumor burden, because also LDH, a known marker of tumor burden, correlated with survival, where high levels of LDH resulted in poor survival. We also analyzed the pre-treatment tumors by exome and RNA sequencing to identify mutations, and shown here in this oncoprint, the usual mutations in GNAC and GN11 could be observed in most of the tumors. We also found mutations in the BAP1 tumor suppressor gene, and in fact, BAP1 status seemed to correlate with response, where we had a higher amount of responders among the BAP1 wild type tumors. We also analyzed mutation signature and the mutational burden in these tumors, and we found that most tumors did not have a high mutational burden as expected from uveal melanoma, but one of them had a UV signature, and this happens to be a patient with an iris melanoma, which we already last year showed in a whole genome sequencing study that iris melanomas can have UV damaged genomes. And interestingly, this patient also responded in the trial. So combining BAP1 wild type status or this UV tumor, it actually correlates with prolonged survival in this trial. We also did immune profiling of the patient's blood, where we could divide patients into those surviving shorter or longer. And both categories of patients, their monocytes were increasing with the therapy. But in the long survivors, we actually had a reduction in neutrophils. Both short and long survivor had an induction of activated T cells. And also by using single cell RNA sequencing, we could observe that genes related to antigen presentation, checkpoints, and transcription factor genes that are known to be regulated by HDAC are induced in post-therapy cells, both B cells and T cells. So the summary is that this PEMDAC trial met its primary endpoint. If you combine entinostat and pembrolizumab, this results in clinical benefit in a subset of patients with uveal melanoma, those with low ctDNA levels with BAP1 wild-type status and UV damaged tumors. And immune profiling in single-cell sequencing suggests target engagement also in non-responders.
On top of this slide, you see the name of the authors of this publication. Importantly, we want to thank the patients and their families for support and contribution to having this trial carried out. This trial is part of the Merck investigator-initiated program, and we want to thank also organizations and institutions for grant support running this. Thank you.
Thank you.
15:30.